Now, welcome to General Senses. And first off, we want to talk about the different kinds of senses. There are different kinds of general senses. They're divided into three different groups. We have exteroceptive, and those are the senses that that are coming from the outside of the body, from the exterior of the body, hence the name exteroceptive. For example, touch, pressure, temperature, and pain. We feel them on the body surface, so from the exterior. Interoceptive or visceroceptive, on the other hand, those are coming from the interior or from the viscera. For example, changes in blood pressure, stretching of the blood vessels. And proprioceptive senses, those are associated with different stimuli coming from the muscles, tendons, and joints. For example, when we change our position of our muscles, tendons, and joints, or during exercising. First one to talk about is touch and pressure, which is a mechanical receptor. And these receptors are going to respond to changes in touch and changes in pressure. We have the free nerve endings. So these are the receptors that respond to them. Free nerve endings, those are nothing fancy going on at the nerve ending, just literally the nerve ending of the sensory neuron. These are found very commonly in your epithelial tissue. They are the simplest kinds of receptors. Like I said, nothing fancy going on at the nerve ending. They sense itching and pain, but they can respond to touch and pressure, but they are mainly the receptors for pain and itch. These are also known as pain receptors or nociceptors. Then we've got the tactile or Meissner's corpuscles. Those are found, these respond to fine touch and texture. So you want to think of things that you use when you're trying to figure out the texture or touch something. So those are found in the hairless parts of the skin and the lips. You'll find them on the tips of your fingers, for example. And they help us distinguish between 2 points. So if you have 2 points touching your fingers, you are able to identify them as 2 points, while even if they're close to each other, because of these tactile corpuscles. The lamellated or Pacinian corpuscles, these are found deeper in the subcutaneous tissue and in tendons and ligaments, and these respond to heavy pressure and vibration. So you can take a look at them here in the skin. They're obviously found in other parts, but to illustrate them, we'll see them in the skin. So this should look familiar to you folks. We have our free nerve endings, okay, and those again are for pain and itch. You also have the tactile or Meissner's corpuscle. Tactile means touch, so these are also responsible for touch. And you have the lamellated or Pacinian corpuscles, and those are found a little bit deeper, and that's why they are going to respond to pressure. Now for temperature senses, those are known as thermoreceptors because they respond to thermal changes. These are some of the free nerve endings in the skin. We have warm receptors and cold receptors. Warm receptors are going to pick up changes in temperature somewhere between 25 and 45 degrees Celsius, while cold receptors are sensitive to temperature between 10 and 20 degrees Celsius. Anything beyond those, so anything above 45 degrees or below 10 degrees, are not going to stimulate these warm and cold receptors anymore. They are going to stimulate pain receptors. Okay, so now we're not going to feel them as changes in temperature. We're actually going to feel them as painful stimuli, either being too hot or too cold. Now your sense of pain, we already said that they are picked up by pain receptors, also known as nociceptors, and those are made out of the free nerve endings. They are very widely distributed throughout the whole body. Pretty much the only part that does not have pain receptors is the nervous tissue of the brain, which seems very ironic. These nociceptors are stimulated by tissue damage. Remember again, tissue damage is going to kill the cells, releasing different chemicals from these cells, and those are going to stimulate these nerve endings to lead to that sense of pain. Okay, it also responds to mechanical forces like bumping into things or extremes in temperature. Pain receptors do not adapt at all. Okay, maybe very little, but again, pain is protective, so we don't want to adapt to that sense of pain. Visceral pain, meaning that do we feel pain coming from the inside of the viscera? Yes, we do. So the viscera do have these nociceptors. We do have the ability to feel pain coming from the inside of the viscera. Sometimes though, because the brain isn't used to getting painful stimuli from the viscera, it'll reflect it back to parts of the skin, and that is known as referred pain. So for example, if somebody is having a heart attack, although it is actually the cardiac muscle that is in pain, but the person might feel it as pain in the left shoulder or the left upper arm, because the cardiac muscle and the left shoulder get their sensory supply from the same spinal nerve. Okay, so they share a common nerve pathway. So it's not just a random piece of skin, it is a piece of skin that shares a nerve pathway with that viscera. Okay, and that is known as referred pain. Right here, this shows you, that heart attack example that we were just talking about. These are the sensory neurons going to the heart, and that is the sensory neuron going to the piece of skin in the left shoulder or the left upper arm. And you see here that they share the same spinal nerve. So again, referred pain is not to random parts of the body. It is to the part of the skin or the dermatome that shares the same common pathway or shares that spinal nerve. Here are some examples of referred pathways. So we already talked about heart attack, where it could be referred to the left chest and the left upper limb. Things that are kind of interesting, you could feel free to take a look at all of these, but a couple of them that I want to get your attention to would be the liver and gallbladder. So if somebody is having a gallbladder attack or hepatitis, for example, they can actually feel it on the skin in the upper right quadrant of the abdomen, or sometimes even on the right side of the neck and the right shoulder. So again, getting a very good very good medical history from the patient, because this patient can come in and say that I've got pain on the right side of the neck and the right shoulder, and you might be thinking, oh, this might be an arthritis thing, while in fact the problem is this patient is having gallbladder attacks. So a good medical and a very good history from the patient are essential. Now for pain pathways. Well, first off, we need to understand that we have two different kinds of pain. There is sharp pain that happens at the time of the stimulus, so at the time of the injury. And then we have chronic dull aching pain that can happen hours and days even after the injury. Each of these are carried on different neurons. So that fast pain are carried on fibers that are myelinated, and they're known as A delta fibers. Okay, again, they're myelinated, so they are going to conduct fast. These are the ones that are associated with the sharp acute pain that you can feel at the site of the trauma, and it usually stops when the stimulus stops. So if if a patient is getting burned themselves, as soon as they remove their hand away from that flame, these acute pains stop, but they would experience this very dull, aching, chronic pain that again could last for hours and days. These are on fibers known as the slow pain or C fibers. They're unmyelinated. When you ask the patient to localize where the pain is, it is very difficult to do so, because it's more like of a, not at one point, but pretty much in the area where this happened. And the pain continues even after the stimulus is gone. Now, these sensory neurons, whether it's the fast pain A delta fibers or the slow pain C fibers, are going to pass through the brainstem. So again, obviously through the spinal cord in ascending tracts, then through the brainstem, and then they have to relate to the thalamus, and then the thalamus will send them to the cerebral cortex. Now, how do we regulate pain pathway? Well, like I said, the thalamus is where we begin to sense pain. It'll then send it to the cerebral cortex, and the cortex will be able to give you a better understanding of the pain. So you could judge the intensity of pain. So, when you ask the patient, like on a scale from 1 to 10 or 0 to 10, how do you grade that pain? Okay, so grading that intensity of pain is the function of your cerebral cortex. You can also localize where the pain is, so the source of pain. The cerebral cortex will produce your motor response to pain. So are you going to run away from the source of pain? Are you going to withdraw your hand maybe? Or, whatever motor response is to that pain. In the cerebral cortex too, especially in the limbic system, that is going to, that's involved in your emotional response to the pain. So is that pain really bad where I'm going to start crying? Okay. Is it bad where I scream or yell? Okay. So that emotional response to pain is the function of the limbic system. We do have different chemicals in our body that inhibit pain. These are found within your CNS. So we've got enkephalins, serotonin, and endorphins. So higher levels of these decreases our pain, while lower levels of these enhances or increases the sense of pain. Now, lower levels of serotonin is also a cause for depression. So you can see how depression and increased sense of pain are both related to low levels of serotonin. Now, how do we treat pain? Okay, because pain, unfortunately, is a common complaint by patients. So I give them non-steroidal anti-inflammatory drugs like aspirin or Motrin, which is ibuprofen. The bad side to this that they can cause irritation of the gastrointestinal tract, so especially of the stomach. Opiates in severe pain, but those can be addicting. Acetaminophen or Tylenol, that's not addicting. It does not cause GI irritation, but on the long run, it can cause liver damage. So as usual, all medications have side effects. Now this would be how to treat like more of an acute or moderate or severe pain. What about chronic pain treatments? You don't want to just rely on NSAIDs or the non-steroidal anti-inflammatory drugs forever, but you want to introduce some exercise, maybe physical therapy. You can even give them antidepressants because, again, remember that serotonin levels kind of have a role in this as well. There's also transcutaneous electrical nerve stimulation, or TENS, where the thought behind TENS is that if you overstimulate the area of pain, that is going to inhibit the sense of pain. And we kind of do this on a personal level. So if you have an area that is painful, you tend to rub it. That rubbing will kind of get your brain's attention to the rubbing, and so that it's no longer concentrating or focusing on the pain. So it's a temporary solution to deviate or deflect your brain's attention to another sense as opposed to focusing on the pain. Now, proprioception, those are mechanical receptors that would send sensory stimuli to the CNS about the body position and the length and the tension of skeletal muscles, so our muscles contracted or relaxed. And we have several types of those. So we have the lamellated Pacinian corpuscles, and those are exactly the same ones that we talked about when we were talking about the ones in the skin. These are pressure receptors in joints. So we said that lamellated corpuscles in the skin detect pressure. Well, they also detect pressure when they're in joints. Muscle spindles, those are stretch receptors that are found in the skeletal muscle. And when we talked about the knee jerk reflex, we said that we are going to stimulate the stretch receptor. These are it. Golgi tendon organs, those are also stretch receptors now, but these are found in the tendons. And those also help in maintaining posture and protect our muscles from overstretching. So when you're overstretching or overcontracting a muscle, you are going to stimulate these Golgi tendon organs, or these stretch receptors that are found in the tendons, and that is going to send stimuli to the brain, and the brain will try to inhibit it a little bit, so to prevent rupture of that ligament and muscle tears. Here you can see these different pictures. So here you can see the stretch receptors in the muscle and how those nerve endings are intertwined with the muscle fibers. You can also see the Golgi tendon organs, and those are found on the tendon. So the white part is the tendon. And again, those are going to detect stretch. What about visceral senses? Well, we do have, like I said, receptors in our internal organs. For example, we have lamellated corpuscles, again, for stretch. And we have free nerve endings. Okay, so they convey information that when you eat a meal and there's a stretch of the stomach, so that is going to stimulate some of these stretch receptors and cause that discomfort. When we have we've got gas in the intestines, that again, the stretch is going to lead to discomfort and pain that can signal, or when somebody's going through a heart attack, again, that we do have the nociceptors that are going to lead to that sense of pain. This concludes general senses, and next we will start special senses.